slowly kind of join as we go. But it's my pleasure today to introduce Ari Gazesh, a PhD candidate in social welfare at UPenn School of Social Policy and Practice, and their scholarly work really aims to tackle barriers and facilitators for sexual and gender diverse youth and young adults well-being through really two arms of research. One is the role of harm reduction and culturally specific protective factors, such as queer kinship, on SGDY health. So that's, I guess, the acronym, and risk-taking behaviors. And two is really developing and evaluating culturally specific clinical care interventions to improve the health of this population. They've garnered $30K in kind of pilot funding from their P50 Center at Penn, all, surrounding their dissertation research. And so I'm going to hand it over to you, Ari. Hopefully I got the last name correct. And I really look forward to hearing your talk.
Great. Yeah, thank you so much for having me today. And yes, this is my dissertation. I'm a PhD candidate at Penn School of Social Policy and Practice, former clinical social worker as well. And today I'll be presenting findings from that PMARC-funded dissertation research, which explores psychosocial and behavioral constructs related to PrEP interest amongst transmasculine individuals assigned female at birth. And yes, there are some acronyms that I will actually also be talking through. Just a note that this is my first time presenting this data because I've been knee-deep in analysis. And so I'm very excited to get feedback. I won't be monitoring the chat while I'm speaking, but I will look through it after. And I'll also be sharing my contact info, and I look forward to whatever feedback folks have. So I'd like to start by just sharing some appreciation for both my funding source and my co-conspirators, without whom this work would not have been possible. And this is co-investigators, some of whom are on this call, my dissertation committee members, my mentors, and my research assistants. To begin, I'd like to provide some context and introduce key acronyms that we'll use throughout this presentation. So PrEP, or pre-exposure prophylaxis, is a highly effective biomedical tool for preventing HIV. Transmasculine individuals, or TMAFAB, refers to people assigned female at birth who identify along the transmasculine spectrum. TGD stands for trans and gender diverse, encompassing the full spectrum of gender diversity. And lastly, CMSM stands for cisgender men who have sex with men. I do want to note that it is somewhat fraught to categorize people based on their sex assigned at birth, but it does speak to the socialization that people have experienced and therefore has utility for both psychosocial and behavioral factors. To lay the groundwork for this issue, I want to describe how various forms of stigma function. Structural, societal, and anticipatory stigma profoundly shape the healthcare access and outcomes for trans and gender diverse people. Structural stigma, which is embedded in institutional policies, healthcare systems, and societal norms, creates barriers to care such as the denial of gender-affirming services, discriminatory policies, and lack of provider competency. Societal stigma, encompassing pervasive negative attitudes and marginalization, fosters hostile environments that deter trans and gender diverse individuals from seeking care due to fear of mistreatment. Anticipatory stigma, the expectation of discrimination based on past experiences, further discourages healthcare engagement and can exacerbate medical mistrust. Bullock and Bauer's frameworks on intersectional stigma underscore how these stigmas intersect with other forms of oppression, such as racism, classism, and ableism, amplifying barriers to care and worsening health disparities for multiply marginalized trans and gender diverse individuals. These overlapping stigmas create a feedback loop of delayed care, avoidance of medical settings, and untreated conditions, resulting in poor healthcare outcomes and heightened health inequities. As we will be discussing, stigmas contribute to heightened risk and limited utilization of harm reduction services, including HIV prevention. Addressing these interconnected stigmas is critical to improving healthcare systems and fostering equity for this community. To fully understand the scope of this issue, it's important to acknowledge the broader public health context. HIV prevention strategies have historically centered on cisgender men who have sex with men. While this focus has been incredibly important, it has inadvertently excluded other vulnerable groups. This exclusion is reflected in funding priorities, data collection practices, and even in the framing of risk behaviors in clinical education. For transmasculine individuals, this systemic neglect creates barriers to both accessing and trusting prevention services. Trans and gender diverse populations comprise individuals whose gender identities do not align with their sex assigned at birth. Nearly 2 million people nationwide identify as trans, and most trans adults are less than 35 years old. However, this population is growing, and approximately 30% of trans adults identify outside of binary conceptualizations of gender. For this reason, I intentionally sampled participants who identify along the full transmasculine spectrum rather than limiting eligibility to binary trans men. PrEP is a promising harm reduction tool because it is highly efficacious, reducing HIV acquisition by up to 96%. Nonetheless, a paucity of research has examined PrEP utilization amongst trans masks. In a recent online investigation of more than 1,800 trans men, about 24% were PrEP eligible based on their HIV risk factors, yet less than 3% reported active PrEP use. In a separate study of about 850 trans-masked individuals reporting sexual activity with cis men, approximately half met PrEP eligibility criteria. However, despite an 84% awareness of PrEP in that population, merely 33% had ever initiated PrEP and only 22% reported active PrEP use. Historically, research has assumed that trans masks have a similar behavioral risk profile to cisgender females who have sex with exclusively people assigned female at birth. However, recent studies demonstrate heterogeneity of sexual identities, behaviors, and attractions amongst trans mask individuals, including sexual fluidity as gender identity shifts. For instance, many participants in my study noted that they did not engage in sexual activity with sperm-producing partners until after starting testosterone. So stay tuned on a paper I'm writing about that, which is outside of the scope for my talk today. But as sexual preferences, behavior, and risk profiles change, it is incumbent upon clinicians to provide concomitant health information. However, although trans masks are at elevated risk for contracting HIV, they are not explicitly included in CDC PrEP guidance. Therefore, clinicians aren't equipped to provide accurate sexual health information, nor clarity on prescription regimen. For instance, the timeline from PrEP initiation to effective prevention is 7 days for anal sex versus 21 days for vaginal or frontal penetration. Genital atrophy, which can result from testosterone use, can heighten risk of tissue trauma during receptive sex and therefore increasing risk for STI and HIV. If providers aren't knowledgeable about this information and therefore sharing it with their patients, then transmasculine people may not realize that they would benefit from taking PrEP. A major barrier to disseminating evidence-based practices is the scarcity of rigorous research in this population. Few studies have evaluated PrEP interest and uptake among trans-mask individuals, focusing instead on cisgender and trans-feminine individuals assigned male at birth. The minimal existing literature indicates that PrEP knowledge, entrance, and adherence, that's the full PrEP continuum, are influenced by intersectional factors, including those specific to trans identity and being assigned female at birth. As such, these barriers and facilitators of PrEP interest and uptake are unique. A key obstacle to PrEP initiation and adherence among trans people is a lack of trust in medical institutions, and this harkens back to the conceptual model I showed. Medical mistrust stemming from previous ill treatment within healthcare settings is attributable to the historical backdrop of unethical government, medical, and pharmacological studies conducted on minoritized and vulnerable populations. Transphobia, which encompasses experiences such as being misgendered in clinical settings, can significantly dampen the enthusiasm for and uptake of PrEP amongst trans people. These negative interactions occur from clinicians who are not trans competent and who may neglect to counsel trans and gender diverse patients about PrEP. Alongside these challenges, many trans people prioritize gender-affirming hormone therapy and express concerns about potential PrEP and hormone interactions, leading to missed opportunities for integrated HIV prevention and gender-affirming care. Social networks are an underutilized conduit for HIV prevention. For trans individuals who face systematic marginalization, bonding, bridging, and linking social capital, which respectively represent intragroup relationships, intergroup connections, and interactions with powerful institutions, is crucial. Given the key role of trust and cooperative relationships in accessing healthcare for trans folks, harnessing social networks is pivotal for refining public health strategies, especially those related to HIV prevention and care. Moreover, especially for trans and gender diverse youth, we can't necessarily modify relationships with families of origin, but we should be able to leverage providers and public health messaging to behoove well-being. Because public health initiatives advocating for PrEP primarily cater to cisgender men who have sex with men, research is clearly needed to ascertain how such messaging may align with trans mass perspectives and how their social networks can be used to disseminate PrEP information. I postulate that trans-masc individuals may seek sexual health and harm reduction information from sources beyond clinical providers, perhaps from sources of social capital. This foregrounds the necessity of leveraging social networks and social media to disseminate accurate and culturally specific health information. My conceptual model, which I've color-coded along my aims, is an adapted version of the gender affirmation framework developed by J. Savelius. It delineates how stigma leads to social oppression and psychological distress, increasing the need for gender affirmation through healthcare. For this study, the part that I adapted was to really conceptualize the relationship between social oppression, psychological distress, and harm reduction practices like PrEP, including psychological moderators such as future orientation and social support, which I'll be discussing further. The diagram integrates the pathways from structural stigma to identity threat and its downstream effects on health behaviors. The key takeaway is that while factors like stigma and social oppression are difficult to change, interventions that address psychological moderators and harm reduction practices can yield significant benefits. My study focuses on these modifiable factors by examining how trans-masc individuals engage with PrEP messaging, navigate social networks for health information, and appraise their own HIV risk. Given my proximity to my research participants, I would be remiss in not acknowledging my positionality. I am a Jewish, white, transmasculine, queer person who would fit the eligibility criteria for my study. As a researcher and clinician, I am committed to the pursuit of partnering with policed and vulnerable communities, using my positionality to attenuate the gap between rhetoric and reality, between policy and practice. At the same time, I must engage critically with my own identity valences. As a scholar who shares many of the experiences of my participants, I carefully tread along insider and outsider classifications constantly. To do so with grace and intentionality requires reflexivity that recognizes what is at stake when inviting subjugated knowledge to become visible beyond its intimate circles, and I must attend to the risk and responsibility thereof. In our current landscape that demonizes my right to exist, I cannot help but feel the weight of my responsibility in this critical juncture. And yet this burden also serves as the whetstone against which I hone my advocacy, intellectual inquiry, and power of positionality. This leads me to the specific aims of this study, which were threefold. First, to elucidate psychosocial factors encompassing depression, traumatic and minority stress, social support, and future orientation that may impact risk behaviors, and I'm including both sexual activity and substance use here, and PrEP interest in a cohort of transmasculine individuals. Secondly, to explore how and from where and whom trans-mascs procure health information, particularly pertaining to HIV prevention, including PrEP knowledge, and how they appraise the relevance of these messages. And thirdly, to describe both the perceived strengths and deficiencies in current PrEP messages, targeting cisgender men who have sex with men that could be adapted or adopted for this population. I'm mostly going to be focusing today on the first two aims, since the third aim will be addressed through some focus groups that I'm actually conducting next week. I used a cross-sectional convergent mixed methods design, recruiting 30 participants who self-reported as HIV negative, met CDC PrEP criteria, and identified along the transmasculine spectrum. Eligibility criteria included that self-identification, so whatever that meant to participants, being age 16 years or older and residing in the broader Philadelphia area. Efforts were made to include participants from varied areas of the city, also racial and ethnic groups and socioeconomic backgrounds. Participants were recruited via purposive and snowball sampling methods. I had a robust recruitment strategy planned, including significant partnerships with community organizations that I've cultivated for the last several years and conducting outreach in community frequently. However, I didn't end up needing it. I posted one flyer, this on the right, on a social media platform, a group called Queer Exchange on Facebook, and I was inundated with responses. When I asked participants how they heard about the study, most mentioned word of mouth through their queer networks, including sharing of the flyer in Discord channels, Signal threads for mutual aid, etc. Data collection was completed in under 3 weeks, which is a testament to the unmet demand for this type of research. A note about the inclusion criteria. I originally phrased my eligibility screener as aligned with the CDC guidance for PrEP, which you can see right above there. But I quickly realized that I was recruiting participants who didn't meet the risk profile that I'd intended. So I had to change 2 screening criteria. The first was to specify that condomless sex occurred with someone assigned male at birth and included penetration. Transmascs who have exclusively cisgender female partners are at a lower risk of contracting HIV than those who engage in penetrative sex with sperm-producing partners. Secondly, I had to specify that injection drug use should not include hormone replacement therapy. The risk differential for someone injecting heroin differs sharply from intramuscular testosterone shots. Quantitative data was collected through an online survey hosted on a secure platform. The survey captured demographic information, sexual and substance use behaviors, HIV-related knowledge, attitudes and practices, PrEP awareness and interest, future orientation, social support, and gender minority stress and resilience. Survey responses were anonymized to protect participant confidentiality. Standardized instruments and validated scales were employed to ensure reliability and validity. I actually also included some questions from one of Sari Reisner's studies. He's one of the only people who's published on this topic. I'm hoping to combine our samples so that we can be powered for more robust analysis. Data from the focus groups, which will be, as I mentioned, taking place next week, will be transcribed verbatim and analyzed using rapid qualitative analysis to efficiently yield action-oriented findings. I will be engaging in an image elicitation activity wherein participants are shown prominent PrEP campaigns and provide feedback on what resonates, what feels discordant, with recommendations for adaptation. We developed a coding template form that will include key domains to organize group data from the discussions about each message, including message acceptability, identity congruence, relevance, deficiencies, and strengths, with additional open text areas to record observations not mapping onto those domains. And just like with the rest of my data, 2 study team members are reviewing each group transcript, including relevant content in templates to create a condensed inventory of each. And then I'll use a matrix approach, creating data grids where each message is a column and each domain or novel domain identified a row. This approach allows for rapid visualization of the entirety of the data and identification of key themes that will be integrated into PrEP-supported message development for transmasculine people in future studies. My qualitative data was gathered through semi-structured interviews conducted via video conferencing and in person. The interview guide was informed by this study's conceptual framework and covered topics such as risk behaviors, decision-making processes around PrEP, experiences with healthcare systems, and informational networks for HIV prevention. Interviews were audio recorded with participant consent and transcribed verbatim for analysis. Each interview lasted between 60 and 120 minutes, thereabouts, and all interviews were conducted by me, a researcher with shared identity. The qualitative data was analyzed using reflexive thematic analysis following the 6-phase approach outlined by Braun and Clark. This method emphasized the active role of the researcher in identifying patterns and themes within qualitative data. The analysis began with familiarization, where transcripts were read and reread to gain a deep understanding of the content. Initial codes were generated inductively and deductively, capturing key features of the data in a systematic manner. Codes were then organized into potential themes, which were reviewed and refined to ensure coherence and consistency with the research questions. Themes were named and defined to clearly articulate their relevance to the study's aims. Braun and Clark actually published a really powerful piece in Transgender Health in 2023, and they delineate how reflexive thematic analysis explicitly accounts for sociopolitical context of both participants' lives and the researcher's own positionality. Specific strategies include explicit consideration of power dynamics. So themes were examined for how they reflected systemic inequalities such as barriers to healthcare access or stigma faced by transmasc individuals. Iterative coding with flexibility. So the coding framework was adjusted throughout the analysis to ensure alignment with participant narratives rather than pre-existing assumptions. And I just want to give a shout out to my research assistants who were invaluable in this process and to the PMARC funding, which allowed me to pay them. Reflexive journaling captured our evolving interpretations and provided an audit trail for me to remember my analytical decisions and their rationale at each stage. And you'll notice in my results, I'm prioritizing participant voices. So quotes and narratives are used extensively in the reporting to foreground their lived experience. This approach deepened the understanding of the nuanced ways in which gender affirmation, stigma, and healthcare experiences intersect with risk behaviors and PrEP decision-making. And I used MaxQDA software to manage and organize the data, enhancing the rigor and transparency of the analysis. Other strategies to ensure rigor include an autoethnography that I've been engaging in since the very conception of this project, frequent reflexivity memos, double coding with my research participants, double coding with my research assistants, member checking with participants, and utilizing a community advisory board. This table, I don't expect you to read all of this, but mostly it's just a gesture toward my approach to mixed methods integration. I utilized integration through both design and methods. So the quantitative findings are applied to the analysis of the qualitative data to potentially understand differences in themes between key populations in the sample. So for instance, those who are aware of PrEP but not using it, those who are actively using PrEP, et cetera. The mix of inductive and deductive coding will identify themes to undergird future inquiry in an exploratory sequential design for subsequent funding applications. The slide is very busy. I don't expect anyone to read it in detail. However, I just wanted to show on the left the memo template that my research assistants and I completed after perusing each transcript. On the right are some snapshots of the current codebook, which continues to be refined through the analytic process. So results. I'm going to start with just stratifying the participant demographics as important insights into the study cohort. So approximately 2/3 of the sample identified as white, while the remaining third represented a mix of racial and ethnic minority groups. 8 participants aged between 22 and 34 years old with a median age of 25. I actually have IRB approval to recruit another 20 participants, and I'll be targeting those who are between 16 and 22 years old. So that's my next endeavor after I finish my dissertation. And there's a broad range of educational attainment from high school diplomas up through graduate degrees. And sexual orientation was diverse, with 60% identifying as queer, about a third identifying as gay or homosexual, and 0% identifying as heterosexual. This was a choose all that apply. Some notable trends regarding housing stability and economic vulnerability. About 20% had experienced unstable housing in the last 6 months, and 25% had engaged in transactional sex work. In terms of mental health and substance use, nearly half the participants reported major depression, and approximately 3/4 reported severe substance use. Social support. So these two bar graphs illustrate a visual juxtaposition. And so really looking at kind of this mirrored inversion that highlights contrasts. This is from the multidimensional scale of perceived social support. And what it's really showing us here is that participants named low perceived support from family of origin, so the top bar is very strongly disagree, versus high levels of support from friends and chosen family. The bottom part is very strongly agree. This slide demonstrates that there are stark disparities between actual and perceived risk in this study. 20% of participants stated that they never use condoms, while 36% use them only occasionally. However, many participants rated themselves not risky at all or at very low risk of contracting HIV, as seen in this bar chart. This table delineates where people, the lower table shows where people have received information about PrEP, including from providers, peers, and social media and marketing. A full third of participants didn't realize that they were eligible for PrEP, instead thinking that only cis men could take it. 23% of participants were currently on PrEP, and over half said that they would consider it in the future. So I want to provide an overview of the narrative that emerged from my findings, and then I'll be showing you quotes to substantiate each. I began with the impact of stigma in its various forms and how it shaped participants' experiences of medical trauma, whether firsthand or witnessed in others with shared identities. These are instances of both social oppression and psychological distress, with which both decrease access and heightened need for both gender affirmation and harm reduction. These identity threats exacerbate medical mistrust, leading many participants to seek health information outside of formal clinical spaces, relying instead on social networks and social media. Chosen family and social networks played a protective role, helping individuals navigate healthcare by adapting their interactions to meet their needs. And the lack of, and I'm calling that shape-shifting, the lack of targeted health information from providers and public health campaigns also influenced how participants assessed the relevance of messaging, which at times resulted in misinformation. Participants' perception of their risk was shaped by their social networks, including a sense of belonging in gay male spaces, and the extent to which harm reduction strategies were familiar within various communities. Another key factor in use of harm reduction was future orientation, which I'll discuss in more detail. So, stigma. Many participants described how structural stigma, such as systemic erasure of transmasculine identities in medical forms or educational materials, reinforce anticipated stigma. This anticipation led individuals to delay or avoid seeking care, fearing negative or harmful interactions. So I want to highlight both that there are some about the names of clinics. The second quote is highlighting that it's not just providers, it's also support staff, including security. And this last quote, I've been scared to change my gender marker on my insurance and birth certificate because I'm scared I'm going to lose access to gynecological care, which I need because I have a uterus and a cervix and vagina. And so these considerations are all the more amplified in our current legislative landscape. For instance, one of Trump's first executive orders last week suspended passport applications that use a gender-neutral marker or request a change in gender. So there are times where people are, I've been getting text messages all week about people's documentation not all matching. So intersectional stigma, the compounding effects of discrimination based on multiple marginalized identities, plays a significant role in shaping participants' healthcare experiences. These experiences of compounded discrimination lead to heightened anticipatory stigma, where transgender individuals expect mistreatment or bias from medical professionals based on their past interactions or those of their community members. For example, a trans person of color might avoid healthcare due to fear of racial discrimination, compounded by the expectation of being misgendered or judged for their gender identity. Structural barriers such as the lack of inclusive healthcare policies or accessible gender-affirming services further exacerbate this avoidance. As a result, intersectional stigma creates an environment where trans individuals are less likely to seek preventative care, address chronic health issues, or engage in essential healthcare services, worsening health outcomes and contributing to disparities. And a note, some of this is the intersectionality of various kinds of chronic issues, history of trauma and involuntary hospitalization, and really the cost-benefit analysis of, is this thing so dire that I need to get it checked out, or am I just going to wait a little while because it might be a traumatizing experience? The impact of intersectional and structural stigma on anticipated stigma cannot be understated. Anticipated stigma, again, that expectation of discrimination, can amplify medical mistrust, creating a feedback loop that further isolates individuals from preventative care. For trans-mass people, this dynamic often intersects with mental and behavioral health challenges. Participants frequently reported heightened anxiety, depression, or avoidance behaviors linked to their experiences of stigma within healthcare settings. In some cases, these mental health struggles became additional barriers to engaging with services like PrEP, as individuals felt overwhelmed by the dual burdens of navigating stigma and managing their health. Examples included that ubiquity of isms, racism, cis heterosexism, ableism, etc. These played out particularly in sexual and reproductive health, with some participants expressing reticence to share their actual risk profile with providers, either because of enacted or anticipatory stigma. So one participant noted, being so afraid of being misgendered and discriminated in healthcare spaces has prevented me from always going to my appointments, which then leads me prolonging my full body check appointments so that I never even get to talk about PrEP. Another participant recounted, it's one thing being Black, but it's a whole other thing being Black and gay. Trans-mass individuals frequently reported experiencing medical trauma and stigma related to their gender identity, sexual practices, or both. These experiences led to high levels of medical mistrust, which emerged as a significant barrier to PrEP uptake. For example, one participant recounted an experience where photos of his mediaplasty were posted on a surgeon's website without his consent. Others described the callousness or discomfort of doctors when dealing with post-surgical complications. Many participants described instances where healthcare providers made assumptions about their sexual behaviors or failed to use inclusive language. These negative interactions were not isolated incidents, but rather part of a broader pattern of systemic discrimination. Participants relied heavily on community networks for health information. Almost every single person referenced Reddit as a primary source of health information, particularly around gender-affirming care, which obviously overlaps with sexual and reproductive concerns. Too many participants described not getting adequate or accurate health information from their clinicians. Instead, social networks and social media try to fill in these gaps. Another function served by these forums was to vet clinicians and institutions. Many participants recounted posting in online forums to find safer access points and/or to share strategies to mitigate potential harm. One person called it the trans grapevine, which I really liked. A sub-theme of social networks included how T for T interpersonal relationships, this is when trans people are dating other trans people, were protective against medical trauma. For instance, participants recounted how their partners supported their medical transition in various ways, including not only navigational support in finding safer providers, but also logistical and material support while prepping for and healing from surgical interventions. The importance of this mutual aid cannot be understated, particularly vis-a-vis failures of formal systems as delineated in the gender affirmation framework, and thereby attenuating decreased access but heightened need for both gender affirmation and harm reduction promotion. Many participants vocalized the centrality of choice, not only in their transition-related medical interventions, but in terms of those they choose to accompany them along their gender journeys. This is particularly salient for those who have experienced ruptures from their families of origin. For many participants, chosen family and intra-community networks were essential sources of emotional and logistical support. These networks often bridge gaps left by biological families and healthcare providers. As one participant eloquently explained, blood is thicker than water. The real saying is the blood of the covenant is thicker than the water of the womb. So taking that to mean the people you choose to intentionally live your life with, sometimes those bonds will be stronger than the people you entered this life. Participants described how chosen family members facilitated access to gender-affirming care, provided advice on navigating systemic barriers, and shared resources like hormone supplies. Chosen family created spaces of belonging and affirmation that were often absent in broader social structures. Beyond logistical support, these networks offered a sense of identity congruence and solidarity, mitigating the isolation that many transmasculine people face. However, the reliance on these networks also highlighted systemic failures as participants felt compelled to depend on community-based solutions in the absence of institutional support. Importantly, these networks also played a critical role in disseminating health information, sometimes filling gaps left by healthcare providers, but also perpetuating misinformation when formal guidance was lacking. This dual role highlights the urgent need to engage chosen families in public health initiatives, ensuring they are equipped to serve as conduits for accurate and affirming information. Many participants recounted seeking to minimize their vulnerability through conforming to binary gender expressions, regardless of their felt experience. As one person shared, they seek to look less visibly queer when they go to the doctor's office, so the only thing working against them is that they are obviously Black. Others reported the need to, quote, perform gender dysphoria or exaggerate their symptoms to meet clinical and insurance standards for accessing gender affirming care. This phenomenon, which I term, and I've written about, I term it performative pathology, reflects the systemic barriers that force individuals to navigate healthcare systems through strategic self-presentation. Structural stigma underpins this phenomenon, as care protocols are often failing to account for diverse gender experiences, requiring patients to conform to rigid expectations. While these tactics often succeed in securing necessary interventions, they exacerbate internalized stigma and detract from affirming care. Participants highlighted the emotional toll of having to mask their authentic selves or amplify their struggles to gain access to healthcare. So this second quote here, someone saying that they really had to amp up their dysphoria so that either the clinician or the insurance company would believe them. So this idea of performative pathology, which I've written about and I'm continuing to kind of ponder, I'm operationalizing this as it encompassing the phenomenon of appearing broken enough to be worthy of being fixed, while attempting to avoid internalizing transphobia exacerbated by social oppression. Examples of this are frequently cited catch-22 that community laments, which is experienced by many trans and gender diverse people, and that's the expert letter of recommendation, written by a mental health professional detailing their diagnosis and, quote, readiness for transition. This letter of recommendation is often required for trans people seeking access to transition-related healthcare, such as hormones and surgeries. Of note, cisgender individuals seeking hormone therapies or cosmetic surgeries, such as facelifts or breast augmentation, require no such letter. Trans people therefore need to demonstrate enough psychological distress to necessitate intervention, but cannot be so distraught as being unable to give consent, especially for trans folks with significant histories of trauma, serious mental health challenges, and even involuntary hospitalization. Retaining the ability to make their own choices about their bodily autonomy is hamstrung by structural barriers to self-determination. And one other note that this shape-shifting, or what I'm calling shape-shifting, um, uh, so multiple participants noted two striking things. The first is that identity concordant providers are often invaluable comrades, not only because of greater sensitivity toward the nuance of these concerns, but also in partnering to shapeshift within these inherently unjust systems. For instance, a participant noted that their doctor used specific insurance codes to get their top surgery covered, while another shared how they've been able to stockpile testosterone because their, quote, doctor lied to the insurance company about how much testosterone I need in a month, so I have a 2-year supply. This is an example of that kind of subjugated knowledge that I am being very careful about sharing, and so I would ask that this is an example that stays in this room, just because in our current political climate, clinical co-conspirators are themselves seeking to shapeshift, often at great potential professional or even personal risk. So, thinking about these networks of information and how they can often serve as a double-edged sword. On the one hand, they provide critical support and solidarity in navigating healthcare systems. On the other hand, misinformation about PrEP was widespread. For example, some participants believed that PrEP was only for cisgender gay men and that it carried severe, unavoidable side effects. This finding underscored the importance of partnering with community organizations to disseminate accurate, accessible information about PrEP, to really bridge that gap between public health initiatives and the lived realities of trans-masc individuals. Overwhelmingly, trans-masc people did not feel included in current PrEP messaging and marketing. Those that did self-described as binary trans men who identified as gay, and felt part of the gay male community, indicating that, once again, social networks and group affiliation are key factors in relevance appraisal. This aspect of the study will be further explored in the focus groups I'm conducting next week. However, key takeaways at this juncture include a clarion call for more targeted and culturally specific inclusion of trans-masc individuals in tailored HIV prevention campaigns. Another critical finding was around perceived HIV risk. Many participants underestimated their risk, often due to dominant public health narratives that frame HIV as a gay male issue. This perception was compounded by limited sex education that acknowledges the diversity of sexual practices and risks among this population. For instance, participants who engaged in receptive frontal, vaginal, or anal sex with cisgender male partners often did not see themselves reflected in HIV campaigns. This misperception of risk has serious implications. If individuals do not see themselves at risk, they are unlikely to seek out PrEP or other prevention tools. Addressing this gap requires not only better education, but also a fundamental shift in how we talk about HIV risk across different populations. This graphic is a model that I'm still refining, but that I hope will be instrumental in delineating how future orientation is a key factor in engagement with harm reduction strategies such as PrEP, particularly for trans and gender diverse youth. Future orientation refers to one's subjective hopes, fears, and aspirations. Those with a more optimistic view of their future, often fostered by supportive networks or positive healthcare experiences, were more likely to perceive PrEP as a worthwhile tool. Conversely, individuals with limited future orientation, often shaped by systemic marginalization and past trauma, deprioritize preventative health measures. For instance, some participants expressed difficulty envisioning a long-term future for themselves, reducing their motivation to engage in proactive health behaviors. For instance, when the world has treated someone like they are disposable, they are more likely to treat themselves as such. One person expressed difficulty in decision-making because they didn't anticipate, quote, making it to this age. Another couldn't have envisioned, quote, an adult woman version of himself, and many alluded to chronic suicidality. However, a significant portion of participants credited finding their chosen families with assuaging their lack of hopefulness for the future. This underscores the importance of queer elders in modeling that it is not only possible to survive, but to thrive. Others pointed to the life-saving components of accessing gender-affirming care. One person pointed out that transitioning doesn't fix your mental health problems. It wasn't like every issue I've had just disappeared when I started taking tea, but I don't really think I would be able to have a life without it. Self-actualization directly impacted their engagement with risk-taking. As one person stated, ever since coming into my personhood, I feel like I take less risks now because I'm concerned about the longevity. I'm concerned about my future. Back then, I didn't have a future. I didn't think I was going to stay alive. I didn't care. But now I do care. There's too much at risk for me to be engaging in risky behaviors all the time. Cultivating hopefulness is a key protective factor leading to better health outcomes, and it is incumbent upon clinicians, researchers, and policymakers to ensure that transmasculine people feel capable of and looking forward to, quote, being old and gray someday. I wanted to end on some powerful testaments to that resilience and healing demonstrated by my participants who are becoming the queer elders that they themselves needed. I'm just going to give you a second to read through this. I'm going to move on to implications for the sake of time. So they span across clinical, policy, and research valences and point to several actionable recommendations for public health practitioners and policymakers. First, enhancing provider training. There's a critical need for comprehensive training for healthcare providers to deliver trans-competent care. This training should address both clinical competencies and the interpersonal skills needed to build trust with trans patients. reframing risk narratives and public health messaging to address specific vulnerabilities and realities of transmasc individuals. This includes creating educational campaigns that are inclusive of diverse sexual practices and partnerships. Beyond individual level interventions, we must also address the structural barriers that limit access to PrEP. And there's a need for interventions that integrate harm reduction, gender affirming care, and comprehensive services. Combining PrEP and sexual health education with mental health services ensures a holistic approach that acknowledges the interconnected nature of these factors. Culturally tailored programs that address the specific needs of transmasc individuals can enhance accessibility and improve health outcomes. And we can leverage community networks to disseminate accurate information. Often community orgs are already embedded and have established trust, making them ideal partners for outreach. This study shares common limitations with other qualitative pilot studies. It is not meant to be generalizable, but rather to outline the contours of a phenomenon, informing the exploratory sequential research I plan to conduct over the next several years. Other limitations include the sample being drawn exclusively from Philadelphia, a relatively liberal urban environment. Additionally, many participants were not on PrEP and some were unaware of their eligibility, preventing me from conducting the rigorous network analysis I had originally planned. Minors were not included in this sample, but will be in future research. Another challenge is the rapidly shifting political landscape. Although these interviews were conducted only a few months ago, healthcare access continues to be stratified by intersectional factors, including geographic location. The specter of federal mandates rear their ugly head, but state-specific contexts and contrasts between urban and rural settings continue to play a role. And finally, as a researcher who shares social location and identity with my participants, I've implemented strategies to acknowledge and account for my positionality and bias. However, this remains an ongoing reflexive process. In summary, this study represents a crucial step toward understanding and enhancing PrEP engagement amongst transmasc individuals, contributes to national HIV prevention efforts, and addresses the urgent need for inclusive and contextually relevant public health interventions. This research not only mirrors the NIH Office of AIDS Research priority of bolstering avenues into HIV prevention services, but also champions innovative HIV delivery methodologies. This study explores the interplay between mental health and HIV vulnerability. As such, we set the stage for integrated strategies that simultaneously address mental health outcomes and fortify HIV prevention measures. I want to emphasize that this work is not just about identifying barriers, but also about highlighting opportunities for change. By listening to the needs of transmasc individuals and in collaborating with community, we can develop interventions that are not only effective, but also affirming and empowering. Thank you for your attention, and I look forward to your questions and discussing how we can translate these findings into impactful policy and practice. And this
Thank you.
QR
Oh,
code is my contact info as well.
that was a fabulous talk. You know, and it's amazing to hear, you know, what's going on, what you're doing at Penn as well, because the P50 or the P30 or 50 center there is more on the psychosocial end, where ours and others are more at the neuro end. But we definitely need to be talking about ways that we can be connecting as well, because it's not just the risk, but you also have, you know, if you're looking at depression and all of these things, it also influences cognitive health. And there's ways to integrate that as well. So, but absolutely fabulous. I'll let anybody have questions?
I have a question. All right. First of all, that just to echo what Leah just said, that was a really excellent talk and really informative to me, who doesn't know much about this area. I was really struck by the fact that PrEP is so successful, yet in the transmasc world is not used. Your numbers were quite low, and you went through a lot of examples of why that is. I was just wondering what do you think is the most significant barrier? Because you talked about lack of knowledge, thinking it's just for gay men, or the mistrust of the medical community, or the misunderstanding that it might interfere with hormone affirming therapy. Like what are if you were to put those in context of what's the most important barrier, most significant barrier, it also kind of says where we should focus our attention. moving forward.
Yeah, I think both the most modifiable and the most urgent factor is actually clinical education. So this is actually not from my dissertation. This was someone telling me a story from yesterday. This is a cisgender woman who's queer. She went to her gynecologist and she asked about PrEP, and the doctor was like, "Oh, I think you're talking about doxypep. I've never prescribed that, and I'm not really sure how to do it." And her last provider was actually a gay male, a gay gynecologist, and he was very comfortable prescribing PrEP. And this is from a gynecologist at Penn, for a cisgender woman. So the fact that there is such a lack of familiarity, and I would say medical mistrust on both sides. So PrEP, a necessary part of that is coming in for blood work every 3 months. And so if providers don't feel comfortable trusting that their patients are going to come back to do that due diligence, they may be more reticent to prescribe. Also, I would like to see a world in which PrEP is counseled in primary care in the same breadth as birth control and condoms. These are tools that we have. We shouldn't have any new infections. And I shout out to some of the clinicians who I know and love and admire on this call who are doing that work. But unfortunately, it's not widespread.
Thanks.
We need to do some implementation science work as well, right? So and I've seen it at where I came from at UIC, right? Even in the OBG world of just implementing, depression screening, which is now kind of that mandating, but you kind of have to go in and try to implement within these clinics.
Yeah, that's actually what I'm hoping to do in my next phase of my career. So if anyone wants to give me a postdoc, let me know.
Well, it seems like you have some amazing options as well. Scott, were you going to unmute, or Chala? I see your faces. Sorry to call out people.
No, it's okay. I just sort of turned on my camera, but I have had the experience many times in clinic of people coming to us and telling stories about, how they were mistreated in just, clinics, not at the university, but in San Diego. And so, Ari, I apologize. I had some divided attention. I don't know whether you addressed this, but is there any approach to sort of identify clinics that are knowledgeable, trained, and safe already so that people can choose to go there and not have to be subjected to misgendering and sort of disrespectful practices, or even good intention but just unknowledgeable practices?
Yeah, this is a primary way that this information sharing through social networks is manifesting. And so one participant called it the trans grapevine. My friends and I call it the queer Rolodex, which is dating us a little bit. But so, and frankly, when I moved to Philadelphia, I posted in Queer Exchange and asked who the safe provider was. And now that's who I go to, right? And so these things are happening across the board, including around a lot of things around what surgeons are safer. And I would say rather than safe, it's safer. It is a harm reduction approach because even if the provider themselves may be trans competent, maybe their staff might not be, or the security guard, as one of my participants noted. So there's systemic barriers at every valence of the medical system. Yeah.
But currently there's no more public sort of, seal of approval sort of thing, that, we're safer here, we're trained and we care,
Well, I think there are,
so.
but unfortunately, that's who decides. So, for instance, the participant who talked about his mediaplasty being posted on a surgeon's website without his consent,
Wow.
that person was saying, "Oh, look, I do this surgery. Come to me, all trans people come and I'm safe, but then there was this massive infraction of consent. So so I will say that ADOS Health Initiative at Penn has been working on coming up with a compendium of resources, and I think there are some others out there as well. But again, it's a mixed bag in terms of if someone is saying they themselves are competent, community might not agree.
See that point. Okay, thank you.
And I see some amazing comments on your talk that are popping up on the, I think Katie just is applauding. I don't know if you want to unmute yourself.
Just wanted to say amazing work and thank you. And I want to say we're here to stand with you and to support this. I know it's a really trying time for all of us, but thank you for sharing this
and continuing to push, right? And I think of work that we do in Uganda, you know what I mean? And around the world where it's not safe at all.
Yeah, the need is not going anywhere, but we'll be shape-shifting our research agendas to get funding however we can. And I, as an early career person, I am looking to many of my mentors, some of whom are here. And, you know, it feels kind of like when a kid is scared and they look to their parent to be like, is this actually a threat? A lot of trainees and early career people are looking to all of you to let us know how worried we should be. And so it's very helpful to both acknowledge the urgency and fear, but also what are some of the strategies that that we can continue to use and have been used in the past. In fact, I'm on a board and for queer clinical social workers, and we're organizing a panel of queer elders in academia and clinical spaces to kind of speak to some of this of like, okay, here's what happened in the 80s. Here's how we got around some of these things. And so if anyone's interested, please contact me, and yeah, it would be helpful.
Anybody else? Honestly, thank you so much for coming and speaking today. I mean, this also shows for our audience, right? The breadth of work. You know, some of us are at the more basic science, some are epi. And so it's great to kind of hear on all different sides, the psychosocial as well. And, you know, that was part, Barb, of, you know, some of the talks earlier as how to integrate our centers to kind of be working together, because we should be. So thank you. Caroline, I'm gonna pass it to you to find out
Sure.
I think Scott's speaking
next week. It's Scott Latendra, and he's going to talk about clinical trials of therapy for brain health disorders in persons with HIV. So that's next week.
My talk doesn't require one iota of the courage that Ari has, so I won't make Katie cry.
But please, Ari, I don't know if you've signed up and have come to some of our other, you know, other Wednesdays, but this is pretty much every week. So spread the word. As Barb mentioned, you know, that this is a community and we want everybody kind of involved.
It's been an honor
Awesome.
to present. Thank you so much.
No, I mean, you're doing exceptional work. That's why when I read it, I was like, are you? So awesome. So thank you guys.
Great.
Happy Wednesday, and we will see everybody same time, same place next week.
And thanks, Scott, for stepping in last minute to do next week. Appreciate it.
Sure thing.
Bye, Ari.
Yeah.
Thank you.